I am so excited about this interview today. I have had the privilege of working with David Rogers for, I don't even know, maybe a decade. I would consider him to be one of the top experts in eating disorders in this area. I've had the privilege of working conjunctively with him as he's treated a client for eating disorder while I'm treating for trauma. He's done that with several other clinicians that I know. So I'm eager to pick his brain on this topic and just hopefully educate myself even more and anybody that may be listening in terms of eating disorders, what's happening culturally, what's happening treatment wise. So I'm going to let Dave introduce himself, tell you guys a little bit about his background.
Tina, thanks for having me. It's an honor, and I'm excited about our talk today. A little bit about me. I started counseling professionally in 1994 and began up in my home state of Maine, private practice setting for about 2 years. Then circumstances led me to Arizona to work at Remuda Ranch Treatment Center for Eating Disorders. And I was with that company. That's the first time I began treating eating disorders. That was in 1996. I was with Remuda until 2011. Variety of positions there, ranging from primary therapist to clinical director. And I have a private practice that I opened in 2011. Still have it open today. And I would say probably it varies from 40 to 70% of my caseload are eating disorders. And I owe probably, if not all of my training and understanding of eating disorders, at least the great majority of it to Remuda. And I had the privilege of working with some very bright, skilled people there. And it's unfortunate Remuda doesn't exist anymore, but I think in its day it could have been the best in the country, perhaps one of the top treatment centers in the world. You know, every treatment center has its strengths and weaknesses. You know, Remuda was no different. There's no such thing as a perfect treatment facility, but I'm very grateful that I had the time there and to be mentored by some very bright people. And let's see, I'm married, got two wonderful daughters, age 25. Yeah, we've been in Virginia since 2008.
Eating disorders scare me a little bit, you know? They can be deadly, different than a lot of the disorders that we treat. How for you, why eating disorders? Why this area? Is it simply because that was your background and where you landed, or is there a personal interest here?
To be honest, it was completely by accident. If you had told me early in my career or when I was a boy, hey, Dave, you're going to treat eating disorders when you get to be an adult, I would have told you you're crazy because it honestly wasn't even on my radar. So when I applied to and got accepted at Remuda as an employee, I remember one of my supervisors there said something that I'll not forget. He said, the ones that will teach you the most about eating disorders are the patients. And boy, if he wasn't right on the target with that. And within 6-7 months, I knew that I got eating disorders, meaning understood them because of the feedback from the patients. And I kept repeatedly hearing this statement, you get me, you understand it. It's such a relief to have somebody who knows what's going on inside of my head. Everybody else looks at me sideways or like I'm crazy. And I noticed that just that in and of itself, you know, brought a lot of relief. And I think all human beings have two core needs. One is that somebody on planet Earth understands me and that we're accepted. And so I think that's really foundational to a lot of the work that we do as therapists. So long answer to a short question, it was by accident. And it just turned out to be a really good fit. And I think Remuda had such a wide range of clientele coming there, from extremely ill, back and forth from the hospital to Remuda, to less ill patients. And it really helped me understand how to adapt to each level of severity.
So, what are the levels of severity? When do you know, first of all, that someone needs to be in treatment for an eating disorder? And then the second piece is, when do you recognize your limitations to say, "Oh, now there needs to be inpatient hospitalization?
Yeah, great question. Let me go through the levels of care and then I'll circle back to when do you know the next level up is indicated. So if you think of a staircase, at the bottom of the staircase is outpatient level treatment. And that means a person is living at home. They might have one, maybe two appointments a week. And sidebar for a second, eating disorders are a multifaceted problem, and therefore they need a multidisciplinary team. Therapist who specializes in eating disorders, not all do. Registered dietitian, preferably one that has been trained and experienced with eating disorders, not all are. Psychiatrist, PCP, who's familiar with eating disorders, and trust me, not all are. I don't think it's automatic that MDs get trained in that as a specialty. So it's important to have a multidisciplinary team because, I might know more than your average person with nutrition just for the mere sake that I've been doing this for a long time, but I don't know the science behind nutrition in the human body the way a dietitian does. So, and same for medications. I'm familiar with medications. I know how some work, but I'm nowhere near trained like a psychiatrist is. So back to the levels of care. So we have outpatient, then we have the next step up in intensive outpatient or IOP. Most of those programs are around 3 hours a day, 5 days a week. The client lives at home and it's a little bit more intensive. Since the pandemic, there is a wide range of remote programs. Prior to the pandemic, intensive outpatient primarily was in person. The next step up is something called partial hospitalization, and those programs range from 5 to 7 or 8 hours a day, between 5 and 7 days a week. Again, the client's still living at home, but as you can tell, the program is far more intense. The next step up is residential, and that's when the client goes to move in and stay at a facility ranging, I'd say, from 2 to 3 weeks all the way up to 2 to 3 months at times if the eating disorder is really severe. And so that level of care is more intensive, and appointments with therapists range from 1 to 2 times a week. See the dietitian on a regular basis, a lot of support groups and psychoeducation. Sometimes there are experiential outings to help clients actually engage the new skill set and encounter challenges that they're going to run into at home when they discharge. There is not an intensive medical level of staff at residential level, which leads me to the next step up, which is inpatient. So an inpatient setting is more akin to a hospital type setting. It's not hospitalization per se, but it's at a level of care where there's a lot more structure. There's a full complement of medical staff ranging from psychiatrist, medical doctor, nurse practitioners, nurses who are there 24/7, around the clock. And that level of care can administer interventions that residential typically does not. For example, the nasal gastric tube. That's a very thin tube that's inserted into the nasal passage through the nose down into the stomach to assist the refeeding process. Can be a tremendous tool, but it does need skilled medical staff to insert it and monitor it as well as utilize it. And then the top step is acute hospitalization. And that level of care is for individuals who are severely medically and physically compromised, and they need intensive care. And my understanding of that level, there's not a lot of therapy going on because the body is in crisis, and that's the main focal point, is refeeding the body and restoring a person physically so that they're ready to take a step back down to inpatient level. So those are the levels of care. Going back down to the bottom step, when do you know that a person requires more than outpatient therapy? A couple of indicators: persistent weight loss. Their best efforts are not getting them to the place where the weight is stabilizing. They continue to lose weight. Exercising compulsively. I could tell you stories. Sometimes people do workouts every day that are just incredible. There's a distorted belief system at the heart of most eating disorders, and it's very powerful and it's very persuasive. And a lot of times that that belief system is, every calorie that goes in your mouth, you absolutely have to burn it off. And there's a misguided perception that my body needs help to metabolize, when in fact our bodies know exactly what to do with food. It's involuntary, and those metabolic processes, they take care of themselves. So significant weight loss, compulsive exercise, purging is another factor that will indicate higher level of care. I would say, 2 to 3 times a week, even though that's serious, it's not to the point where it's going to start causing significant damage, at least in the short term. When those parameters are superseded, then we need to go look at being evaluated for a higher level of care, be evaluated for that higher level of care and find out that they've surpassed that, and they might recommend residential or inpatient. So back down to outpatient level of care, typically therapies once to twice a week. And if that's not working and the client is trying, but they're not gaining ground, or they have very low motivation to recover and they're at risk to themselves, those would be some indicators that would require them to go to a higher level of care.
Yeah. So I'm going to take this back a little bit and look at it from more of a cultural perspective, and then move more to specific things for family members and other people that may be interested in this topic. But what role do you think that the macro culture and social media play in body image?
Well, media, in a word, as long as there's been media, they've played a role. And, if you look at the old adage is, does art shape culture or does culture shape art? I think both do. But back to body image, media holds a mirror up to the culture about what's desirable, what's not desirable. And I think it plays a huge role. Let me touch base on social media and internet. I think the fashion industry has gone through some significant changes. For example, I'm dating myself, but 1940s, early 50s, the actresses that were looked up to, Katharine Hepburn, Audrey Hepburn, if you look at those old films and look at their waist, it almost seems surreal how thin their waists were. And I've heard stories, I can't verify them, that sometimes there were devices underneath their clothing that would pull their waists that tight. Then we got into the late 50s, early 60s, and what was desirable changed again. Marilyn Monroe, Jane Russell, full-figured was what was desirable, and it hit the culture in that respect. And then around 1966 and 67, Twiggy showed up, and her nickname kind of is telling. She was a British actress, and she was drastically underweight. And she revolutionized the fashion industry. I honestly don't think we've recovered since. And so those are some macro culture or larger cultural issues that have shaped body image. Then we had the induction of the internet, and I think things took off. If for no other reason, access. Once we all got this little smartphone in our hands, you can access anything you want 24/7. And I think there's a good body of research out there now that indicates that social media has tremendous impact on body image. And, the amount of scrolling that teens, and to be fair, even older people do on a day-to-day basis, I mean, I got to watch myself, is incredible. And if you just expose yourself to those things day after day, they're going to have an impact. And unfortunately, there are some websites on the internet that are just, I guess the best word I could use is diabolical. They are pro-eating disorder sites that can take people down some very, very dark and dangerous paths.
So, how about friends, family, just daily interactions that people have? How does that impact body image?
Very much. Think parents, and I want to say this respectfully, because I think most parents that have an adverse impact on their children on this point, they don't mean to. But let's deal with the role of moms first. How mom regards and speaks about her own body is incredibly important. If a mom is comfortable in her own skin and doesn't draw undue attention to her body and, lives a healthy lifestyle and takes care of herself, in contrast to a mother that is constantly and verbally picking apart her body. I'm so fat. Oh my gosh, I hate my stomach. This looks disgusting. Gosh, I'm never going to look right. They have an audience. And I heard a statement about parenting many years ago. Be careful where you're going because somebody's following you. As parents, whether we want to or not, our kids, they look to us. We're the center of the universe for them, until they get older. And the example that we set in what we speak about and teach, they're watching. And, I don't even have to aim those remarks at my child for those to have an adverse impact, because I think most kids were hardwired to look up to mom and dad. And if mom is perpetually unsatisfied with her own body image, that can rub off on the child and teach them to be nitpicking and critical of their own body. Let's go over to dad. He plays an immense role in his daughters' lives. I think it's been said that sometimes fathers have as much or more impact on their daughter's idea of femininity than the mother. And I've heard stories where, a dad and a daughter are out getting something to eat, on a sidewalk cafe, and dad will say, get a load of this woman over here, like she needs a Big Mac. And hey, check this one out over here. It's like, oh my gosh, look how big she is. Is he saying anything to his daughter? No. Does he need to? Absolutely not. She gets it. She's listening, and she is clearly understanding what he values and what he doesn't value. And so fathers have to be very careful in terms of how they speak about women and what they say and choose not to say. So that's the family. Siblings can have an impact as well. I think all of us tease our siblings to one degree or another growing up, but I think where it crosses the line is when it becomes incessant and bullying and, shaming the other person's body. Friends can have a tremendous impact as well. I remember shortly after I started working at Remuda, I was stopped in to get myself an ice cream on a hot July day, and there were a small handful of girls in front of me, I'd say 12, 13 years old, and I noticed they were doing something, and they were touching their wrists, and it dawned on me they're body checking. And I thought, oh my goodness, at this younger age, that's what's going on. So I think friends can have a tremendous impact in that way. Back to the social media. When I was growing up, it took gossip a week to get around the school, and now it's around the school in 30 seconds. And so kids truly grow up in a different environment than us older folks did. And, damage can be done much faster in a bigger scope now that the technology's there to do it.
Yeah. Talking with my last guest about women and attractiveness and body image, and just normalizing that this pressure has been on women to
Yep.
be attractive, to be desirable, to have this focus, your physical appearance. What are the variables that tip someone over into a disordered way of thinking about body image?
Yeah, great question. I think to one degree or another, everything that we've talked about so far, but also let me address anorexia in particular. When I was working at Remuda Ranch, one of the therapists there educated me that anorexia in particular can be a developmental disorder. And the onset of anorexia is peak at two particular age brackets, 11 to 14 and 17 to 2. And you think about those two age brackets, the operative word is change. And so let's take the first one, 11 to 14, transitioning from childhood into adolescence. And I know there's exceptions, but in general, childhood can be a bit carefree and not a lot of responsibility, and interactions are definitely not conflict free, but they're a little simpler. And then we hit puberty and the social landscape changes. And, people that I was playing with in elementary school, now it's middle school and people are checking each other out. Everybody's body's changing. I think all of us, even under ideal circumstances, feel pretty awkward about it. there are more responsibilities upon us when we become teenagers. And there are some times, whether it's conscious or unconscious, a young person can say to themselves, I don't want this. Teenage life is too hard for me. I miss childhood. And it's an attempt to revert back to childhood. I'm going to starve these curves off me. I don't like the female parts of my body, or as a male, I don't like how my body's changing, and I'm going to get rid of it. And that may be conscious or unconscious. Another factor that might trigger in terms of the developmental aspect, you think of the second bracket, age 17 to 22. Again, operative word is change. Most people are leaving the nest or going off to college, and sometimes that is overwhelming. I've had many freshmen in college get to college and say, oh my gosh, these classes are way harder. I don't know how to do my laundry. There's way more sexual activity going on here at college. Frat parties, on and on. I can't do this. And an eating disorder may be a one-way ticket back home. And what's really going on is they're over their head with all of the changes that are coming at them regarding adulthood. So those can be some triggering factors for anorexia in particular. I think there are times that a single trauma can put an eating disorder in motion. You know, severe sexual trauma or sexual abuse oftentimes causes women to have shame toward their body when actually the shame belongs to the perpetrator, but it changes the way that they think about and relate to their own body. And it may be a way to punish it or starve it or, quote, make it better, especially if they were insulted about their body. So those are some precipitating factors that are common to get eating disorders in motion.
At one point, people would say most that suffer from an eating disorder have sexual abuse in their past. Is that accurate, Dave?
In my experience, I don't have research right at my fingertips to back this up, but a general guess is at least 50% of the population of eating disorders probably have some degree of sexual mistreatment or abuse in their past.
Yeah. So is it similar to addiction, Dave, where you're just in this compulsive cycle that now has taken a life of its own?
Yes, I would say most people regard eating disorders as a process or behavioral addiction. And then we have chemical addictions that kind of speak for themselves, alcohol, drugs. But back to the process addictions, the behavior itself becomes addictive. And example, gambling. There's not necessarily any drugs involved. Now, in the brain, there is dopamine, which is being released, which reinforces the gambling behavior. So that's an example of how a non-chemical addiction operates. With eating disorders, it does become addictive. You think of some of the hallmarks of addiction: increasing behavior and built up tolerance. I used to skip breakfast, but now that's not doing it. I got to skip lunch. And eventually that's not doing it either. And I'm going to knock out afternoon snack. And I build up a tolerance. The body goes into survival mode or starvation mode, and metabolism is altered. And there's some degree of payback. Otherwise, people wouldn't do these behaviors. A working definition of addiction that I think has been helpful, at least for me, is an attempt to meet legitimate needs through unhealthy methods. And so the eating disorder, whether it's binging, purging, compulsive exercise, laxatives, what have you, there is some kind of internal benefit that reinforces the behavior. And even the negative aspects of it that people don't like and they hate, it puts them at war with themselves, and it breeds shame. Like, what's wrong with me? Half of my brain knows this is crazy behavior, so I must be ridiculous. And what do they do with all of those feelings? They go back to the behavior to either numb the feelings or to self-punish. So yes, it has a very addictive quality to it.
What is your approach to treating this? I'm sure it varies by person, but big picture, what's the approach?
Yeah, great question. The basis or framework that I've used is contextualism, which basically means most human behavior is best understood in the context that it happens. And sometimes we look at people from the outside and we scratch our head and say, what are they doing? But if I was in their shoes, the lights would go on and I would say, now I know why they're doing this. So all of us deal with a couple of contexts. One is my environment or current circumstances. Those have quite a bit of influence on us. The other context is my inner life, how I process information, my thoughts, my emotions, my beliefs, my history, my memories. And if you put those two contexts in place, it goes a long way to explaining why this person is doing what they're doing. So, on that note, I think it's important for clients to not only know what they're doing, but why they're doing it. All human behavior is purposeful, and you can't battle something that you don't understand. So, one of the early tasks, if people are open to it, and they're not always open to it, is helping them understand their own behavior. And once that threshold is crossed, it can paint a bit of a roadmap in terms of what does this person actually need. You know, circling over to the addiction model, we could get an alcoholic to just stop drinking. And is that better? Of course it is. Their liver is going to stop being punished, but it doesn't necessarily or automatically address why are they doing this. And so effective recovery not only addresses the behaviors, but the underlying root issues as well. And I often think of recovery, the end goal is that a person feels whole, that we haven't just stopped a bunch of adverse behaviors, but we've gotten this person to really understand themselves and why they do what they do, and to replace the maladaptive behaviors with ones that are helpful and adaptive. So in general, that's the framework that I use. There are some eating disorders like ARFID, which is a newer eating disorder that is more anxiety based. And it's not body image related. And that requires a different approach that's called exposure therapy. So, but that's a general framework that I use.
Okay. You had made mention earlier of your early days of treating eating disorders and just getting the feedback from clients of, oh my gosh, do you get me? I mean, it's a big deal when someone says that to you. So, what is the common conversation in the mind of somebody that's struggling with this? What's going on in their head?
Obsessive thinking, it usually starts for many the second they wake up. When body dysmorphia or severe body dissatisfaction is present, it has an obsessive quality to it. There are parallels between body dysmorphia and OCD itself. What people obsess about is different, but in short, the obsessive thinking and the compulsive behaviors are just cyclical and relentless. So I think most people that battle with eating disorders, even if they don't admit it, they will acknowledge there's a civil war going on inside. I often hear people say the eating disorder has its own voice, and then there's my voice. And I've never once heard someone say the eating disorder talks to me nicely. It is a brutal taskmaster. It is shaming. It's never good enough. Critique, critique, critique all day long. It's relentless and it's exhausting. And people are in real trouble when they cannot distinguish their own internal dialogue from the eating disorder voice. It's a better prognosis when people can distinguish the eating disorder voice, so to speak, or that thought process compared to their own internal dialogue. That is more helpful. But I think also with most eating disorders, there's a lot of shame. The self-talk is nobody will understand this. If I told anyone they'd think I'm crazy, they'd tilt their head and say, what's wrong with you? So I'm just going to suffer in silence. And it's very isolating, and people with eating disorders feel incredibly alone at times. So that's a short summary of some of the thought processes that take place.
Yeah. So you mentioned body dysmorphia. And so, the continuum of over here, which being a woman in the world today, all the way over here is body dysmorphia. What are the distinctions here between body dissatisfaction and body image distortion and dysmorphia?
Great question. Body dissatisfaction is what it sounds like. I just don't like my body. But they see and perceive what the rest of us do. When they stand in front of the mirror, they don't see a drastic difference in what you or I would perceive. Dysmorphia, on the other hand, it's essentially like looking in a circus mirror, that their eyes literally give them feedback that is so distorted, and it's powerful and it's persuasive and it's dangerous. the rest of us could coach this person and encourage them. And gosh, you really don't look that way. And why do you think this part of your body looks that way objectively? Honestly, I'm not blowing smoke at you. It really doesn't. And their eyes tell them something completely different. And so that's one of the most baffling parts of eating disorders, that people who are unfamiliar with eating disorders or don't understand them, scratch their head, and it just doesn't make sense. And to a great degree, it doesn't. But
Right.
the person suffering with dysmorphia, it's terrible, and it drives them to spend way too much time in front of the mirror, trying on 10, 15 outfits in the morning, getting perpetually frustrated, body checking throughout the day, walking down the sidewalk. And if there's a glass storefront, all through the day, just looking incessantly, seeing if they're fat, or if there's been any changes in the last few hours even. So yeah, dissatisfaction is I don't like what I'm seeing, but I'm seeing reality. Dysmorphia is a distortion.
So, what forms of body checking typically take place?
I mentioned one a moment ago, excessively frequent visits to the mirror, checking different body parts, my wrist, collarbone, hip bones. Though another form of body checking is how my clothing is fitting. It gets to the point where somebody believes, my purpose is for my clothes instead of, no, my clothes are for me. That's what's normal and healthy. But even the slightest variation in how an outfit might feel um, will have a major impact. And that is a form of body checking. So weighing oneself up to 20, 30 times a day, that's another form of body checking. So those are probably the most common.
Okay. And so, as an intervention, how do you advise them to manage this type of checking?
Yeah, it's difficult. And on this note, in recovery, usually body image disturbance is the last one to go. Unfortunately, it's stubborn. It's more long term than short term. And I think people, once they realize, and there's some techniques that you can use to show somebody how distorted their perception is, that they simply have to remind themselves probably every day, I can't trust my eyes. I remember that time that we did the distortion test and how far off I was, and what my eyes are telling me, what my mind is telling me is not really reality. And, when people give in to those distortions, they reinforce them. And again, I have compassion for these people. This is easier said than done, but they have to push back against it. Instead of, I don't feel comfortable going out because I'm afraid people are going to be staring at me, they need to go out. And they need to expose themselves and, find out that what they fear is going to happen is not happening.
Which is what? That everybody sees what they see?
Yes. I've met folks that, I'd really like to go for a walk or a run, but I know what other people are going to be thinking. This is the dialogue that goes on in their minds. Is that a fact or an assumption? It's complete assumption. We have no idea what other people are thinking. But if I convince myself, oh my gosh, if somebody sees me, it's going to be a disaster. So don't even go out. And so that's an example of how it can impact somebody's behavior and cause them to alter their behavior. And, this kind of irrational fear that's not based in reality, it's still fear nonetheless. And it's powerful. When we know we're up against an irrational fear, I can't avoid it. I got to go right at it. That's how they're broken. If it's a rational fear, pay attention. But if it's irrational, I have to do the opposite. There's a DBT skill called act opposite. And in short, that's what's needed.
Right, right. The young lady I was interviewing prior to this one was saying the intervention her mother used was she would show her pictures of herself, but remove her head out of the picture. And that was how she began to see the distortion, was to be able to look at it like it was someone else, which she could see very clearly. So, you
Wow.
think about the process. How do you cross over into that level of distortion? I'm sure, again, it's so multifaceted, but it's because you have fed this sickness or you have fed this disorder so much that you really have lost the ability to see reality?
Yes, on this particular point, and I've often said the task is to trust the perception of people I trust, and I know they support me and they have my back until my eyes stop playing tricks on me. And again, much easier said than done, but if my doctor is telling me honestly, you're fine, you're in a healthy weight range. There's no concerns. And I see something very different in the mirror. I have to make a decision. Who or what am I going to trust? And again, it's very difficult for women afflicted with this or men. But I think having a close, at least a small handful of people who I trust and I respect and they treat me well, to trust their perceptions at times until my distortion starts to dissipate.
Yeah. Okay. That makes a lot of sense. So, as we start to wrap this up, a lot of folks will ask, as loved ones, as good friends, support systems, how can we support somebody that's in recovery from an eating disorder? And what challenges are we going to face?
Great question. I think pay attention. If you suspect a problem, don't ignore it. Now that we have the internet at our fingers, Google or research signs and symptoms of an eating disorder to give you an objective reference. What am I looking for anyway? And you're typically going to find some very helpful information there from reputable sites like Mayo Clinic or WebMD. There's many. IADEP, NIDA, those are eating disorder organizations. And if it seems that your loved one is exhibiting a handful of those signs and they're continuing, approach them in private in a loving way and say, hey, can we have a talk? I don't mean to put you on the spot, but I've been noticing some things lately and I'm worried about you. And I've noticed this and I've noticed this and I've noticed this, and to be specific. And do you feel comfortable talking about it? I'm concerned if this continues going that it's going to hurt you. And eating disorders very frequently have a big element of denial. And sometimes people will shut the conversation down, they'll change the subject, or they might even get angry or lash out. And that's very difficult. And sometimes it might take more, I would say it often takes more than one talk or one meeting. Sometimes it might take a family meeting or a family intervention. And it's important to approach those folks with compassion instead of, tremendous frustration. I think when people get scared, that can come out in some not so helpful ways. I mean, even me. And so we got to be composed when we approach these people and, suggest that they see somebody and get checked out, because this is the kind of problem that you want to get earlier on. The research is really clear that the earlier you intervene on an eating disorder, the better the prognosis, that the future of treatment is much better rather than 5, 10, 15 years after the fact. Then it's very difficult to turn it around.
Yeah. So, I'm hearing you say, don't ignore it, get yourself educated, and determine how you may want to approach the person that's suffering, because I imagine people's tendency is to look away and not address it. What would you say about the people that you've treated? Who has been the one that has spoken the truth into their lives?
Yeah, I think it's family members. Sometimes it's a friend that loves this person enough to tell them the truth. And they're uncomfortable conversations, but I can think of a client I worked with a while ago that it was a good friend that turned them around and had a very candid conversation with them. And the client had tremendous respect for that friend, and therefore their words carried a lot of weight. So it really depends. Sometimes people grow up in families where they don't feel safe or they don't trust their family members, and it might be a friend that gets through to them. Other times it's a family member that gets through to them.
Okay. Thank you. This has been very helpful. It's been nice to take a step back and look at it from several different lenses. But is there anything else that you would want an audience to know about eating disorders, the treatment of eating disorders, or even the role of a bystander in viewing treatment disorder?
I think for support people, be available. That's the main thing, is be available. We live in a busy culture, and we got to be available. Ask questions, do a lot of listening. I think that's something all of us could do better is listen. Excuse me. You may even want to research some local support in your area, just in case the time comes that they need to be connected with some local resources. You'll have them on hand. And me, Psychology Today is a good resource. International Association for Eating Disorders, or IADEP. That's a good resource that can help find some local resources as well, or online support groups.
Thank you. Thank you for taking the time to talk to me today. And just, I can tell you, I know professionally several women that you've really walked out of this into recovery. And I know that you've helped tons more. Thank you for what you do. And are you accepting new clients?
I am accepting clients, and I appreciate you having me on today. It's been a lot of fun. And
Absolutely. And if somebody wanted to find you, Dave, how would they do that?
an email address, david.rogers, ROGERS, the number 6, ymail.com, not Yahoo, but the letter Y, mail.com. That is probably the best way to reach me. I have a business number, 804-922-1486 as well.
Awesome. Well, thank you so much.
Thank you, Tina. Take care.
You too.